everyone. Welcome to Thyroid and Menopause. My name is Dr. Kathleen Jordan. I'm Chief Medical Officer of Midi Health. Midi Health is a telehealth platform I'm proud to say is now serving 50 states and help women navigate all the challenges that come in midlife, particularly around menopause and perimenopause. A lot of our patients are also encountering thyroid disease, so we frequently work with Paloma Health, and I'm here to introduce Dr. Heather Krantz. Want to say hello?
Hi, hi everybody. I'm glad to be here.
Great. Dr. Krantz, you want to talk about Paloma Health and a little bit about your background?
Sure. So I do work with Paloma Health. Paloma Health is a website dedicated to thyroid care. So my background really has to do with women's health. I've been in women's health my entire career. I am an OBGYN. I did residency in medical school at University of Kansas and 30-something years ago. So, I've worked in a lot of different practices, all involving women's health, and I really got interested in thyroid care kind of twofold. I was interested in integrative medicine. Women, as you know, Dr. Jordan, are very interested in their health care and are interested in all kinds of alternative things. So I ended up doing a fellowship in integrative medicine. Kind of got me interested in supplements and all different kinds of lifestyle options of helping people's health. And then of course, in the midst of all this, I ended up developing a thyroid problem. So that's really how I got interested in thyroid care, because honestly, I had a lot of this frustrations with the healthcare system, even as a doctor, that my patients have, which is kind of an interesting thing to end up dealing with, just to be on the other side. So that's kind of my story. And what about you, Dr. Jordan? How'd you get it?
Great. Well, I have to say I am a midlife woman, so I actually have had the joy of experiencing perimenopause and menopause, and really one of the impetuses around starting Midi Health was really to improve access to evidence-based care. People confuse integrative medicine as thinking it's not evidence-based, but there's a lot of science behind many of the integrative interventions as well. I do want a couple housekeeping things. We are going to talk about topics in general. This is not intended to be specific medical advice, but you can always come to Midi Health or Paloma Health if you want individual medical advice. And then if you have questions, put them in the chat. We're going to talk for a while just to cover commonly held questions, and then we'll have some Q&A at the end. So put your questions as they come along the way in the chat, and we'll get to ones that we can. Okay. So why are we talking about thyroid and menopause together? Well, the first thing that comes to my mind, and you can add to it, is because the symptoms overlap and the people that get and are experiencing both overlap significantly. So they do coexist quite a bit, right? So, I had a patient yesterday actually that has been receiving thyroid care for a long time, and the symptoms she thought were getting exacerbated. She thought her thyroid levels were off. It turns out they weren't. Her endocrinologist said they were spot on. But when I talked to her, she was actually 49. 51 is the average age of menopause. And actually what she thought was worsening thyroid symptoms was actually very classic symptoms of menopause. Very similar, right? If you think about fatigue, weight gain, brain fog, even heart palpitations, anxiety, lots of overlap. So that's why we're here today to talk about it, because it also affects the same women. Obviously, menopause and perimenopause hits in midlife. And Dr. Krantz, why don't you talk about sort of when thyroid disease hits women in general?
So thyroid disease is super common in women, and it's probably 10 times more common in women than it is in men. The incidence of thyroid disease increases as you get older. If you look at population studies, and this kind of depends which study you're looking at, but hypothyroidism, which is really what we're talking about, tends to be, maybe around like 4% or something when someone's like in their mid-20s. But by the time someone is like 50, it's more like 15%. And then it steadily increases as you get older. So it's more, maybe approaching 20% as someone reaches 70 years old. So it's super common. And especially there's a lot of overlap, like Dr. Jordan was saying, that, around that perimenopausal age, kind of mid 40s up 50, you really sort of see a bump up. which is confusing, like you were just talking about with
Right.
symptoms.
Right. And there are some women that get it earlier, and this actually
Yeah,
happens with menopause as well. So about 6%. So all women will go through menopause, if assuming you live long enough, right? But about 6% actually go through early menopause, and
yeah.
1% can even be in their 20s and 30s. Same thing with thyroid disease. So, so when do you screen for thyroid disease, Dr. Krantz?
So I tend to start screening people when they're probably in their 40s, honestly. You know, there are guidelines about, checking the TSH, which is the screening test that we use
Mhm.
to see if someone's hypothyroid. But honestly, I think checking earlier is more useful just because it's more common than people think. And just even from my own experience, there are things we can do if we catch it earlier, like especially, bring up the whole Hashimoto's issue. If somebody has Hashimoto's and has antibodies, there are lifestyle approaches we can take before somebody really is overtly hypothyroid. So it's kind of nice to know that. And most of the time we don't. And even in my own case, I didn't know, until it was really obvious.
Mhm.
What
So
do you think, Jordan? I mean, what would you say would be your age for checking a TSH?
Well, so we have the benefit of, when you look at menopause, there's the classic presenting symptom that your periods stop, right? Or your periods are changing would be a symptom of perimenopause. So perimenopause is the really 5 to 10 years leading up to menopause where you're getting hormone changes and you can get symptoms. So you have changing periods, which is actually a trigger that it's actually happening. So you don't necessarily always need lab values. Now, if you have an atypical or a confusing picture, maybe you've had a hysterectomy, maybe you have an IUD, and maybe you're on birth control pills. So there may be other reasons that you would actually screen. Then lab values can be helpful.
Right.
So you don't actually, different to thyroid disease for menopause. If your period stopped for 12 months, you're in menopause. I mean, we obviously make sure you're not pregnant or something else, but if you're the classic age, period stop for 12 months, you're in menopause, you don't need a lab value, you can actually start treatment. I think thyroid disease is, we rely on labs maybe a little bit more. Is that fair to
Yeah, I
say?
would say that. We really do rely on that TSH level as a diagnosis. And bringing up what you were just talking about, the premature menopause issue. That's another thing. That would be a real kind of gold star reason to check someone's TSH, because autoimmune things tend to run in packs. I like to tell patients, if you have one, you might get another. And a lot of times premature menopause is an autoimmune related kind of issue. So then they're more predisposed to something like a Hashimoto's disease, which is also an autoimmune issue.
Which
Um,
reminds me, so estrogen is an anti-inflammatory. I'm oversimplifying some complex science here, but yeah, changes in estrogen are related to it has been proven to change our inflammatory markers in the blood. So there is a hypothesis that early menopause can actually trigger some of the changes that may trigger Hashimoto's, which may
right.
trigger hypothyroidism. That's the hypothesis linking what we know epidemiologically to be true, is that inflammatory markers can increase as estrogen decreases. So I find that to be very, very interesting. Which brings me, so we were talking yesterday, Dr. Krantz, about the interplay with thyroid hormones and estrogen and
Yeah.
progesterone. You explain it beautifully. So they are related, right? So, and they can affect each other. So we can talk about estrogen and progesterone because they have slightly different interplays. Progesterone actually facilitates T4 to T3 conversion. Estrogen actually affects thyroid globulin. So what does that look like in patients at Paloma, and what does it in a practical terms mean that we have to do if we have thyroid disease and are going through menopause, perimenopause?
Well, we were talking about how as you go through menopause, estrogen levels start dropping, obviously. And we're talking like natural menopause, not, hormone replacement therapy kind of situation. And
Mm-hmm.
that if somebody already is hypothyroid, then, their requirements for thyroid replacement might actually drop. But part of this has to do with the carrier proteins in the blood and how, how those change as as you drop in estrogen levels. And then if someone goes ahead and decides to start hormone replacement therapy, then their requirements for thyroid hormone replacement can change again. That we can see these bumps up and down. And Dr. Jordan and I were talking about, part of it depends on kind of what hormone replacement you're taking and how likely it is to change your thyroid needs. But it's just something to be aware of, and the same thing happens to women they're younger. If they're on birth control pills and then they quit, then all of a sudden their dosage for thyroid hormone might decrease. Or pregnancy, same kind of situation. And it all has to do with these increasing and decreasing estrogen levels. So it's just, it's not dramatic. It's just something to be aware of.
Right.
And doctors aware of it, because honestly, not all doctors are.
Right. So if we see someone whose symptoms are changing, we would actually sort of finish their titration with hormone replacement therapy. So often that takes 2 or 3 times. Different to thyroid disease, when we are doing hormone replacement therapy for menopause, we will do we'll start a dose and then see how your symptoms do. We may need to titrate up, we may need to titrate down, we may need to adjust the progesterone, we may need to take the estrogen. And remember, the progesterone and estrogen do have slight impact on your thyroid replacement. But we would finish the titration, which may take a few months because you really want to give each titration a month to see if you have to go up or down. Mm-hmm. After that, we would then potentially recheck your thyroid disease. So, because the impact is not massive. It's not that you need to be concerned about it in that you think it's going to wipe out your thyroid replacement, but you need to know about it so that you can recheck should symptoms occur. And I would say much of the time we don't end up changing the thyroid disease, but a few of the times we do. Has that been your experience as well?
Yeah, I agree. And, I usually tell patients just to be aware of it, like you were just saying, just because, it might change. And a lot of times healthcare professionals really aren't aware that it can be impacted by that. So.
Okay. So let me ask you some common questions. So let's say they come to Midi Health, they get an abnormal TSH of 11, and they were looking at hypothyroidism and someone with symptoms. That's why we sent the lab. What does best treatment look like?
For thyroid replacement?
For thyroid, yeah.
So if someone comes in and they have a TS, let me go into like the levels of TSH. Let's start there. So, when we screen people, we're looking for what a normal TSH would be. And a normal TSH, is more like 2.5, 3, anywhere in that kind of 1-3 zone is kind of what we look for as a normal TSH. Mm-hmm. When we talk about something called subclinical hypothyroidism, which I kind of hate the term, it's kind of a misnomer because it implies that people don't have symptoms, but a lot of times they do. That's when the TSH is kind of below 10. So kind of in that 3 zone. Above 10, like Dr. Jordan just mentioned, 11 is considered overt hypothyroidism. So above 10, we're going to start somebody for sure on thyroid hormone replacement. And what does that look like? It really kind of depends. And, I guess that's one of the things that, I really enjoy doing at Paloma is we really kind of approach it in an individual kind of way. And, and as I'm sure you guys do at Midi Health with hormone replacement, the same kind of idea. There's a lot of different options with thyroid hormone. And traditionally, levothyroxine is the traditional kind of thing we give people. Mm-hmm. It's simple, it's cheap, it's a once-a-day kind of thing. It works really well. What we find, though, is probably about 20% of patients don't feel better necessarily on that replacement. So there are other options out there. Sometimes we will move to something like a natural desiccated thyroid, like an Armour, or we might move to adding a T3, separately, or, we might move to different brands. It kind of just depends. So, that's kind of what we do with thyroid in terms of making it kind of individualized.
And then once you start on treatment, how often do you recheck labs, and what's that follow-up look like?
It takes, just like with the hormone replacement, it takes time to kind of like, I like to tell patients, fiddling with it a bit. We have to fiddle with it a while to get them the right kind of regimen. And some people it's really easy. It's like, oh, you start them on levothyroxine and you adjust the dose a little bit, check a couple times, woohoo. You know, there's guidelines as to kind of like estimating what dosage they need based on their weight and things like that. But other folks, it really takes a bit of effort, and it can take, you know, 6 months to kind of get it to where you need it to be. And we'll usually check, you know, while we're adjusting it, we'll usually check like every 6 weeks or so.
Mhm.
Sometimes a little longer, just kind of depending on the patient and kind of how out of whack it is. But we'll check like every 6 weeks and then we'll readjust, you know, and then, you know, it depends. I mean, you know, what we do then, if we get them kind of all nice in gear and they're still having symptoms, we start looking at kind of other things.
Very
Like
good.
hormone replacement if somebody's having menopause symptoms.
All right.
Yeah.
I'm gonna redirect to another common question or clinical scenario that comes up at Midi. So at Midi, we do help women in midlife with weight management, right? So weight is a contributor to several health factors: hypertension, diabetes, high cholesterol, cardiovascular disease, biggest killer of women, right? So we really help women navigate this. Sometimes it's medication, sometimes it's lifestyle interventions. But we do have women that come that have in the past or are interested in taking thyroid medication. And sometimes not prescription they've taken, or sometimes it is prescription. And they want to take thyroid medication to really help them with weight loss.
Yeah.
I'd love to have you share your thoughts on this.
So my thoughts are that thyroid medication is really not meant to be used directly for weight loss unless someone is hypothyroid. Using it for weight have normal thyroid labs is really unsafe. And you know, we sometimes see patients come in trying to self-adjust their thyroid medications to kind of bump up their metabolism to lose weight. And you know, there is a little bit of a realm of normal in terms of labs where we can kind of move around in there, but we don't want to make someone hyperthyroid. And if someone is buying things like on the internet, like you can buy like bovine hormone supplements, thyroid hormone supplements, or, you know, ground up thyroid, basically, that's really not regulated well. And it's really considered unsafe. I've also had patients, like you were mentioning, get stuff from other countries, borrow thyroid hormone, whatever, from friends or relatives to try to bump up their metabolism. But what ends up happening is they can make themselves sick and they can make themselves hyperthyroid. They can have all the repercussions that go with being hyperthyroid, like bone loss and cardiac issues, arrhythmias, things like that. So we really discourage it.
Yeah, we do the same. And the other thing I want people to know, and when women sort of bring this up, there are other very effective
Yeah.
solutions that can help with weight loss. So there's much healthier means. I don't, you know, as Dr. Krantz was mentioning, taking too much thyroid actually it's a cardiac stimulant. I'm trying not to give you a heart attack. I'm trying to help your health, right? So our goal is long, sustained, healthy weights, healthy metabolism, and a healthy and happy woman, really. So there's lots of other alternatives. Some of it's lifestyle interventions that are effective. It can be anything from timed eating, adding fiber, nutrition changes, or it can be medications, right? There's the new GLP-1s, but there's also other longstanding medications that have been shown to help. Things like Contrave, metformin, things like that. So there's other solutions that can help, and I really often redirect women that way in the interest of their health. Okay, so let's talk about lab values, right? So tell us, so TSH we use as a screener. We often order it at Midi, right? How do you end up being reactive in whether you're deciding on which 20% may need T3 versus regular? What do you do with the T4, T3 levels?
Ah, that's a good one to ask.
Sorry.
That's okay. It's really individual. And you'll have patients come to you a lot of times and they will tell you, I want my T3 to be this, or I want my T3, T4 to be this. Because there's all kinds of information all over the place about, you should ask your doctor to be at this upper limits of normal or whatever. I find it really is individual. I do have patients who have strangely low T3 levels, and it's very obvious that they need extra T3. by and large, I kind of go more by symptoms in terms of whether I add T3. And then, I just basically want it to be in the normal zone. I sometimes will have patients who they're like, but I want my T3 higher. I'm like, how do you feel? And if they feel fine, then I'm like, leave it alone. Because like you said, T3 can, especially out of the two hormones, can be a cardiac stimulant and can give you all kinds of symptoms and make people anxious, make them feel all jittery, even give them AFib if it's too high, atrial fibrillation, so an arrhythmia. So, I don't try to get too stuck on the actual lab values as long as they're in the normal zone. We do try to keep things in the normal zone. You know, what do you guys do with your hormone replacement? And that's a totally different realm because it's not as picky, I guess I would say.
Yeah, so we do labs. I find labs to be very motivational for women. I also feel like women are like, see, I knew this was happening. I do use it obviously we don't have to have it. If you're 51 and your period stopped for 12 months, you have menopause, you can go on treatment without labs. Absolutely. If you're an outlier though, so if it's a little bit confusing because maybe you have thyroid disease actually, or maybe you've had a hysterectomy, or you have an IUD, or it's your periods have always been abnormal, we'll check an FSH is usually a big screener for whether you're in menopause or perimenopause. The problem with labs and whether deciding on hormone replacement therapy is in the perimenopause phase, your hormones are on a roller coaster. So when you pick a day in the month that you pick the hormones is not necessarily reflective of where you are on the trajectory. So for about 5 to 10 years, women go through a roller coaster, but the overall roller coaster is trending down. But if you happen to draw the labs on a high peak day, it may not reflect the profound symptoms they get on the nadir days. So I feel like the women in perimenopause often go the most neglected. They're waiting till their periods stop to justify going on hormone replacement therapy. But I think women in perimenopause can really benefit from hormone replacement therapy. And we see that time and time again in our patients. And when women do wait until full menopause, I get this comment, probably the most common. Every day I see patients, I hear this, right? So it's, oh my God, I feel so much better. Why didn't I do this 5 years ago? So you don't have to wait till full menopause to benefit from hormone replacement therapy, because that roller coaster can be quite frustrating, actually. So that's my big message to women. I waited too many years too, so I can give that from personal experience.
I did, because I'm an OBGYN.
Good. That's good. Okay. So there's some questions coming in, and I'm going to have to get my reading glasses out because I am a midlife woman, right? So there's questions coming in. There's lots of women sharing that when they went on hormone replacement therapy or went into menopause, their thyroid levels changed. And there's some questions about how quickly do we expect that to happen? Do you have any thoughts on that, Dr. Krantz? Like, is it in days or weeks or months? And when?
I mean, I would check, if you start hormone replacement therapy and, like Dr. Jordan was saying, it takes a little while to kind of get it in gear to the right level. I would kind of wait till you are mostly getting in gear, which is probably a couple of months, and then check a TH level or check your thyroid panel just to kind of see where you stand and if it needs to be adjusted. You don't want to be sticking people, for blood draws constantly. But I think this is a reasonable amount of time.
Right. And in general, I think we usually wait a month, 4 to 6 weeks, right, to really make sure that we're picking up the changes that have occurred with all hormones affect so many things, but it takes a while to reflect, right, in these hormones, in these hormone cycles.
In terms of the hormone replacement, you have to realize there's all kinds of things going on behind the scenes in terms of carrier protein levels changing and things like that, and that all affects hormone replacement, estrogen and progesterone replacement, as well as thyroid replacement. So it does take time.
Okay. Another question for you, Dr. Krantz. How often should I get a full thyroid panel check if I've had a history of Hashimoto's? And this is a great opportunity too. A frequent question. When do you need and when do you get thyroid antibodies, not just T3, T4? And what does that mean?
So as far as like the full panel, it really kind of depends. If we get them to a perfect spot and their thyroid levels look all nice and good and they're happy, you could check it every year at their yearly visit. I mean, that's kind of where I am right now, is check it every year. But when you're in the midst of figuring it out, it really depends. Or if there's a lot of like variability or some sort of labile, you're going to check it more often. So, that just depends. TPO, that kind of too. I mean, a lot of times, one of my major frustrations is that people don't get their TPO checked early on, like when they're diagnosed. I mean, this when I went to the doctor, she's like, well, why do you want to know what that is? I'm like, because I want to know if I have Hashimoto's, because I want to know if I have an autoimmune problem. She's like, we don't do anything different. I'm like, well, yeah, we can do things differently. So there's a lot of misunderstanding about that.
Mm-hmm.
On the other hand, TPO can be really frustrating. People will have a positive TPO, which is, just to explain to everybody, is the antibody that's positive when somebody has Hashimoto's disease, or is one of the main antibody. And we use it to sometimes track kind of what level of inflammation is going on in the body, and we can use it as a reflection of the changes we're making, maybe in lifestyle or diet changes, plus being on thyroid hormone. So at that point, we might check it more frequently. Later on, when we get people stable, we might check it every year with their lab panel, and just to kind of see what it is. But sometimes we get it at a certain point and it just doesn't change. It just stays there. And then it just becomes frustrating for people to look at it every time they get it, because we have Hashimoto's. Okay, it's there. Does that kind of answer the question?
Exactly. I'll just say, for people coming
Yeah.
late, thanks for coming to Thyroid Disease and Menopause with Dr. Krantz from Paloma Health, and I'm from Midi. I'm going through some of the questions here and comments. I love a lot of comments on our weight conversation. Thank you for someone who contributed that exercise also helps metabolism. Absolutely. We're talking about how there's alternatives to taking thyroid medicine to help you lose weight. There are much healthier alternatives. Exercise is absolutely one of them. I actually blog about it because it's my 2024 goal to do it myself more. But it actually changes insulin sensitivity. So it actually helps moderate your use of glucose, which actually then translates into hunger, and it translates into fat storage. Exercise has been shown to decrease your risk of breast cancer. Exercise has been shown to increase insulin sensitivity, which overall helps with metabolism and insulin. So exercise, it's not just about the calorie burn that you get with exercise. It actually is good on your end metabolism as well. So thank you for that comment. It's very important. And I love the nurse who, well, I assume you're a nurse because that's your handle, says no to thyroid disease for weight loss. Thank you very much. I just had a consultation. I was wondering why my testosterone was not addressed or given a thought for prescription. Great question. So traditional hormone replacement therapy is replacing what we are depleted with the most, which is estrogen and progesterone. So typical hormone replacement therapy in menopause doesn't include testosterone, because we have we actually continue to make testosterone. Those levels don't drop as precipitously as the other two. We have a lot more data. Again, maybe we are committed to evidence-based health. We have a lot more data on the safety, efficacy, and good outcomes of giving estrogen and progesterone. Testosterone, one, is a controlled substance. So it comes with all the regulations. It means you have to have face-to-face visits. You can't get that many refills. It's a little bit of a hassle, would be sort of an understatement a little bit. But also, most of the trials are done in men, and you're looking at 10x the dose. And it's very hard to translate that data to women. For women, the best real evidence is that it can help with libido, and even that evidence isn't fabulous. Like, it can help with libido somewhat. There is some data in helping muscle building, and there's evolving studies on if it helps with brain fog, but I would say the data is not there. It's conflicted, actually. So traditional hormone replacement therapy is estrogen, progesterone. Even the data in men with testosterone is in men who have very low testosterone, so are testosterone deficient. So we do prescribe testosterone, but in general, what I do is and I do this the same with thyroid disease, it's very hard and it's not best practice to actually start 10 different medications at once. You don't know what side effects are coming from which medicine, what benefits are coming from which medicine. And when you're talking about things like menopause, we're talking about taking these medications potentially for decades. So I want to know that this is the one that worked for you and this is the one we're going to keep you on. This is the one that made your hot flashes go away. This is the one that made you sleep. So then we would keep you on it. If you start 4 things at once, you don't know which one worked and which one you need to stay on. So barring emergencies, I would definitely try to pace myself. Typically, if someone screens in for thyroid disease at Midi, we would make sure they get that started first and then start hormone replacement therapy. How do you handle that at Paloma?
Yeah, so it's kind of the optional thing versus the not optional thing. So at Paloma, I would say we got to get their thyroid in gear because that's the not optional thing. I mean, people need to have thyroid hormone to live. And while you might feel like you're going to die because you need replacement, you actually won't. So I really try to get the thyroid normalized before we send them off to, if they need to get hormone replacement therapy. And partly that's just because, like we talked about earlier, there's such an overlap of symptoms. So when someone's, say 50 and they're just kind of working through getting on thyroid hormone, we really try to get it to where it needs to be, at least, in the ballpark, basically. And if they're still having symptoms, then, I might suggest, you might talk to your gynecologist about getting on hormone replacement. Now, having said that, I would do it like in tandem, just because if someone's having hot flashes, or it's really obvious that it's menopausal symptoms like vaginal dryness, that kind of stuff, that's not. So then, I might send them off at the same time while we're adjusting things.
Yeah, I would do the same for sort of classic symptoms.
Yeah.
Because you can follow them and what's responding. So it's great. Okay, I have another question here, Dr. Krantz. What about food and supplements? Are there any you frequently use or recommend?
Oh gosh, that's a whole topic. Yeah, and for menopause too. I mean, you can tell, like Dr. Jordan and I both, it's sort of, when people reach menopause and when they're having hypothyroid or Hashimoto's issues, there's so much more to talk about than other than just medications. And that's a big piece of it. But there's so many other things like exercise, lifestyle issues, things like what supplements might you add, or what dietary maneuvers might you make. I mean, for us at Paloma, we see a lot of people with Hashimoto's. So we are kind of like targeting certain things, like we might target certain dietary changes, like trying to eliminate gluten and see if that helps, or trying to eliminate dairy and see if that helps. There's a whole autoimmune protocol diet that we sometimes use, not always, but sometimes, that can be helpful. Supplement wise, it really kind of depends. I'm with Dr. Jordan. I tend to not be one of those people that throws a lot of stuff at somebody. And I think sometimes patients can get frustrated because they want, a list of 10 things to do. But if, psychologists who study those kinds of things find that if you give people more than 3 things to do, they don't do any of them. So I tell patients that, I'm like, I'm going to give you 3 things to do. Do these 3 things, come back and tell me how it worked. Because otherwise I don't know the forest for the trees as to which thing did what. And same, the converse is, I have patients come in and they're on 20 supplements because they keep adding things. I'm like, okay, how can we consolidate this and eliminate some stuff, pare it down? What's the real goal here? Are we just trying to target the antibodies and reduce those, or are we, trying to target other things? So that's kind of how I approach it. How do you guys do it?
Very similar. I mean, we have a full-time naturopath and several people like yourself trained in integrative medicine. So we've looked at all the evidence behind interventions that really are science-backed and help. So I would say, when we look at, let's take hot flashes, for example. So if you look statistically at outcomes, hormone replacement therapy is going to be your best chance at eliminating hot flashes and night sweats. Some people don't want to take hormone replacement therapy, or maybe they can't. Maybe they've had a breast cancer. That would be a typical reason you wouldn't get hormone replacement therapy. There's lots of other things you can do. Some of them supplements, like black cohosh is probably the best studied. So there are some supplements that actually help. So it really depends on the symptom. If your symptom is trouble with sleep, we end up doing a lot of supplements for sleep. It kind of depends. Is your sleep because you're up, anxious, and stressed? Is your sleep issue, you know, related to hormones and the changes from menopause, right? So sleep can be multifactorial. So I find a lot of people might take ashwagandha, or we can do cortisol manager, which actually helps decrease the stress response at night that can contribute to being awake. So there's lots of supplements that can help with the symptoms that come with menopause and perimenopause. And we also compare that to sort of the FDA approved formulation, traditional prescriptions, and which ones. And I find that people often choose a combination. So we may start hormones, or we may start Veoza, or they might start an antidepressant, right? And get the benefits of those. And then for other symptoms, do a supplement or integrative lifestyle intervention.
Right. Very similar approach.
Yeah. I've had another question coming in. What about taking birth controls, progesterone only or estrogen only? So for women in perimenopause, you are still getting your periods. For most people, this would be typically your 40s. You can still get pregnant, right? So it really kind of, whether we choose traditional hormone replacement therapy or birth control pills, really kind of depends on your symptoms. So if you have an IUD in place, or you have abstinence, or have no chance of getting pregnant for various reasons, maybe we'll use hormone replacement therapy, which basically is estrogen and progesterone in slightly lower combinations. By and large, birth control pills contain an estrogen and a progesterone, so it's a version of a birth control pill. The question brought up SLIND, which is progesterone. So if you have very heavy periods as one of your symptoms in perimenopause, there's a bunch of strategies to help with bleeding. Some of it's hormonal, some of it's ultrasounds, making sure nothing else is needed. Dr. Krantz, you've actually dealt with this a lot as an OB-GYN. So women in perimenopause that have a lot of bleeding, how do you approach their hormone therapy?
Well, I have to admit, I guess my favorite thing ever is the Mirena IUD. Just because, you know, it does have a little bit of progesterone on the IUD, but for women going through their 40s who do need birth control, especially if they don't want to take birth control pills, or there's maybe reasons they can't take birth control pills, or they're scared of it or whatever, the IUD is just this fabulous item that usually minimizes or gets rid of your period. As long as you can deal with that and you're not scared you're pregnant all the time, you know, usually people do a couple pregnancy tests to convince themselves that the thing really works. It's a really nice way to segue into menopause, I have to say. You know, just because you could keep it all the way up till you're 52, and you know, the one drawback is, as you would say, Dr. Jordan, is then you don't have a period, you don't really know, but you could check an FSH, or you can decide, you know, at a certain time just to take the IUD out, find out. It is a really nice way to segue through all that, so you don't have heavy periods or the kind of on again, off again kind of thing. So
we work with OB-GYN practices for women that benefit from Mirena IUD, which can be a great option too, particularly if they are not good at regularly taking their oral progesterone,
right,
or have side effects from the oral progesterone. But that's great. Thanks. All right.
And different people.
Okay, I have a common question that we get, and let's both tackle this.
Okay.
I'm on both hormone replacement therapy and thyroid medicine, and I can't lose weight no matter what. Okay, you first.
You know, that's so frustrating. I tell patients that, you know, I try to optimize their thyroid. I try to get it kind of in the low normal range, even to try to maybe optimize their metabolism. But I also tell patients it's not magic, that, you know, it isn't going to make them just drop the weight. They have to do all these other options of lifestyle and everything. You know, I will say one thing about getting it kind of in the low normal range is that sometimes people get more energy. A lot of times when people get on, you know, their doctors maintaining their TSH higher, they just don't have the get up and go do stuff. They don't want to exercise. They don't have the energy to do it. So I try to optimize it. And then we, just like you guys do at Midi, you approach it with all the other avenues, you know, in terms of dietary interventions. We'll have people talk to the dietitian, we'll have them talk to the health coach, you know, all those other maneuvers that you can do. But there isn't any one thing. that's going to solve the problem, so to speak.
It is multimodal intervention. And even if you look at the new drugs, right, the Ozempics, the Wegovy's, those studies all included diet and exercise and lifestyle interventions as well. So it's our metabolism changes in midlife, period. It just does. We need to change our diet and lifestyle in response to it to really maintain our healthiest selves. So there has to be a component of that. I think if you really want to be successful at weight management and optimizing your health. The other thing, I couldn't agree with you more, Dr. Krantz. It's, making sure we take the time for ourselves for regular exercise, leaning in. As we eat less in midlife, what we eat really matters, particularly if you're going on a weight med that is decreasing the amount you eat. So what you eat really matters. So you need high quality multivitamin mineral food. So a mix, the colorful plate, leafy greens, all that. You actually need sleep too. That's another thing I talk about with weight gain a lot. Statistically, poor sleep is linked to weight gain. People theorize it's from a lot of things. One, you're tired in the day, so you're less likely to exercise. You also reach for carbs because you're looking for energy. For whatever reason, poor sleep is linked to weight gain. So I also would, work on optimizing sleep. Sleep is a huge issue in midlife. 60% of women have trouble sleeping. There's a doubling of sleep apnea. There's a doubling of restless leg. There's a lot of stress as we manage our parents. Aging parents are somewhat stressful teenagers sometimes, or just like increasing responsibilities at work, financial troubles. There's a lot going on in midlife that can negatively impact sleep. So focusing on sleep actually helps with weight too, which is sometimes a surprising conversation. I think people expect the nutrition and exercise conversation, but sleep less so.
Mm-hmm.
Yeah. I want to make sure that we stick with our time frame here. Do you have any sort of this is this is Thyroid Disease Awareness Month and Thyroid Awareness Month. So what would you like our listeners to be aware of, particularly our listeners in midlife?
So in terms of thyroid awareness, I would just like people to realize that it is so incredibly common. And sometimes you need to ask your doctor to screen for thyroid problems. It doesn't necessarily mean it's going to be the reason why you're gaining weight or whatever the problem is, but I think it's worth looking for. I think it's worth early, especially if someone has Hashimoto's. There are all kinds of things that can be done even before starting hormone replacement, thyroid hormone replacement therapy. So it's worth looking into. It's all about an awareness issue. And I guess that's the main thing I would have from all this. The other thing I would say is, if you're going to go talk to your doctor about thyroid problems, like say maybe your TSH borderline or it's abnormal, prepare before you go talk to them. Think about what thyroid disease is. I mean, there's all kinds of, like Paloma has all kinds of information on their website that you can look at in terms of learning about it, so you can ask informed questions. I mean, I'm sure Dr. Jordan would say the same thing applies to hormone replacement. An informed discussion is so much more productive, honestly, than me just teaching you this is how your thyroid works, which I'm glad to do. Believe me, I do it all the time, every day. But I would love to have that back and forth, that collaboration about, well, this is why I think you should do this versus that, and you having questions about, well, maybe I want this, medication. It's all a collaboration, just like with hormone replacement. It's a collaboration, finding out what best works for you to make you feel your best.
Yeah. No, I couldn't agree more. I'm so appreciative you joined us on the webinar. The only thing I would add to your incredible statements is that the changes of hormones actually do interplay with thyroid disease.
Yeah.
So if you're midlife, just make sure I would optimize treatment for both. So optimize treatment for menopause, perimenopause, and optimize treatment for thyroid, and you can feel really good.
Yeah.
So you can feel better. There's no need to suffer. That would be my main message. All right. All right. We'll sign off there. Thank you, everyone. I'm at joinmidi.com, palomahealth.com if you need help with any of your hormone care.